We know rivaroxaban is very effective at reducing the stroke risk for patients who have atrial fibrillation. It's obviously used to treat pulmonary embolism and DVT. But there's been kind of a knowledge gap for its use in patients with cancer-associated thrombosis. So what we're doing here is talking about the safe and effective use of rivaroxaban for treatment of cancer-associated venous thromboembolic disease, and it's a quality improvement initiative. So I'm with Dr. Simon Mantha, who is an MD and an MPH and a hematologist at Memorial Sloan Kettering Cancer Center in New York. First off, congratulations. It's great to see a study like this. Can I ask you first, before we talk about the study itself, why did you do this study? This knowledge gap we're talking about, is that it?
So for more than 10 years, the gold standard for treatment of venous thromboembolic disease in a cancer patient has been intravenous heparin, which is in all cases is an injectable, which carries a lot of inconveniences for the patient, carrying syringes around, having to self-inject or having it's painful. It can leave bruises, and it's very costly in the range of $2,000 or $3,000 a month. So clearly there's a need there to have an alternative anticoagulant, and obviously warfarin doesn't work very well, so that's been proven a while back. So what we did, we have slowly introduced rivaroxaban as part of our practice. So obviously at Sloan Kettering, we only see patients with cancer, and cancer has a high risk of venous thromboembolic disease, so it was not difficult to find patients. So essentially since early 2014, we have started offering rivaroxaban to patients. We gave them the offer of enoxaparin or rivaroxaban. We explained the bulk of data with enoxaparin, and we said the only reason to go on rivaroxaban would be convenience. And the vast majority actually go on rivaroxaban because in the long term, it's one tab once a day. And this essentially was a quality assessment project. And from then on, we followed them over time for complications, essentially recurrent venous thromboembolic episodes, major bleeding, clinically relevant non-major bleeding leading to discontinuation, and of course, all-cause mortality.
So how many patients and what did you find?
So we found that the risks of recurrent VTE and major bleeding were quite low. For major VTE, it was 4.4% cumulative incidence at 6 months. And for major bleeding, it was 1.6% cumulative incidence at 6 months, which is pretty good compared to past data.
Now you went ahead and you reduced the dose for elderly patients. Sure. Was that more than 75? Was that the
Yeah, so
the cutoff?
If an individual is age 75 or more, we decrease the dose. So for the first 3 weeks, instead of giving 15 milligrams twice a day, we gave 10 twice a day. And for the remaining of the duration of the treatment, instead of 20 once a day, we gave 15 once a day.
So how did that work out?
It works very well. It's just that by our own experience, we've seen bleeding episodes in patients of that age who had been given full dose. And as you know, this drug is clear renally and by the liver, and the renal function goes down with age.
Right.
So it makes sense to say that probably those patients need less. So empirically, based on our personal experience of bleeding, we did that, and we didn't have any bleeding problems when that food was followed in those individuals.
So I found it interesting that you have people who were absolutely anxious to take this drug, very happy to take it, even though the fact that the data wasn't there at the present time.
It's a lot about quality of life. You know, when you have cancer, you have very unpleasant treatments, you have to go to the doctor very often, and it's cumulative, and at some point patients say, I just can't take it anymore, I can't inject, and in some cases you need to rely on a caregiver to administer, which can be very taxing and difficult for them.
Now, you've established clinical pathway guidelines to guide rivaroxaban use for cancer-associated thrombosis. Are these going to be published?
Yes, so it's going to be in the oral presentation today, no, not today, Monday. And then we're preparing a paper, obviously, and we'll go in great details about this clinical pathway, which has a lot of little caveats, lots of little details about patients who should not get the drug. It's not as simple as Lovenox, where there's few simple rules to follow.
So what are some of the things that you need to remember?
So we suggested not to administer to patients who had a weight less than 50 kilos or greater than 50 kilos. We suggested not to give it to patients who had hematuria, gross hematuria, or had any GI/GU lesion. The problem with the urine is that rivaroxaban is excreted unchanged at a large amount in the urine. So we've had multiple cases of bleeding in patients who had a lesion, sometimes completely occult, but that was discovered by giving rivaroxaban and started having hematuria pretty soon after starting the drug. So for that reason, we don't think it's a good choice for those patients. So we put that as a relative contraindication. We break those rules sometimes, but we put it out there that it's not ideal. Same thing for GI lesion. If somebody has a big fungating mass in the stomach and the anticoagulant is going to bath that mass, the risk of bleeding is quite high, higher in our minds than with an injectable. So those patients might be better off with the old standard.
What do you tell patients in terms of what to look for in case there's a problem, in case there's a side effect?
So, for this drug, there's only one side effect, bleeding. It's pretty simple. Now, obviously, it can lead to mortality, especially intracranial hemorrhage. So what I tell them is, typically when you see bleeding, it's going to be GI, in the toilet, like red blood or black stools. If they fall and hit their head, I tell them to go to the ER to have a brain scan because the risk of bleeding the head is significant. And then they can also have hematomas, and I mentioned, well, you could have a mass growing in your thigh if you fell, and then it gets worse and it's painful, things like that. They don't have so much of other problems. They have some nosebleeds sometimes, more than with Lovenox. Vaginal bleeding for women who are menstruating, I think it's more common, but those are what I call nuisance bleedings.
So for the most part, the rates of these were really low in this particular
Yeah,
study.
so the really type of bleeding that people want to know about is major bleeding because it's very well defined. You could say it's a life or limb-threatening bleed, something that kills you or almost kills you. It's well defined in the literature and it's been in studies for a while. So that risk was only 1.6% at the 6-month time point. That's quite low.
So anything else we should know?
Well, obviously those data come from a retrospective analysis. So ideally we would want to do a prospective randomized study, but we're not sure it's ever going to get done because there's difficulties to do that.
Right.
Yeah.
And it's an approved drug. It's off-label.
It's already
obviously.
approved for all cohort of patients. And in the landmark studies of rivaroxaban, there were about 5% of patients with cancer. So there is not an exclusion for patients with cancer not to take it. So it's completely fine, under the FDA approval to administer this drug to a cancer patient, as long as someone has given explanations about the fact that Lovenox has a lot of data for safety and efficacy.
Well, please look around at ASH Clinical News because we have a lot of coverage from ASH 2015. And for ASH Clinical News, I'm Rick McGuire.